Hi, this is Long. Welcome to our video series on search patterns for the most common studies in radiology. Please note that this is an introduction to study interpretation. An enormous amount of detail is omitted for brevity. Continue dedicated reading, seeing as many cases as possible, and keep getting feedback from subspecialists during the course of your training. All right, today we're going to talk about a basic approach to the ultrasound of the first trimester pregnancy. I'm mostly going to be focusing on the addressing of acute complaints for early pregnancy. Routine imaging of pregnancy is frequently done by, OB-GYN. I'm kind of, this is really focused on the addressing of any sort of concerns that occur in that first trimester. These can be pain, bleeding, or, when we don't know the location or viability of the pregnancy. So this is the sort of study that will be requested of radiology. Okay, so big picture, how do we take a look at this exam? What is the overall structure of our approach? So it's really important to understand what's going on with the patient. How far along is the pregnancy? Do we have a serum HCG? Is there any history of fertility treatments, prior interventions? Have they been imaged before during this pregnancy? Things like that. What is laterality, location of patient's pain, if any, or other symptoms? Those sorts of things can be helpful. Then we'll go through the study QAing, and just basically, like with all ultrasound studies, making sure that you have, to what extent are we seeing the fullness of the anatomy? Are we seeing it on grayscale color? Do we have spectral Doppler as needed? And it's important to know, by the way, that if you are scanning real time, that these should be done, all transvaginal exams, done with a chaperone, allowing the patient to insert the probe themselves. Patients, to be respectful of, variations in patients' preferences as to whether or not they are, are amenable or will decline the exam. These sorts of things they're really important in doing these sorts of exams. And a special sort of consideration for pregnancy imaging or imaging, especially early pregnancy, is to avoid use of colored spectral Doppler on the uterus if there's any possibility for a normal pregnancy. Obviously, if especially there's pain, we're going to be using those on the ovaries to assess for torsion or various ovarian abnormalities. But you're going to avoid using that anywhere near or where there could be a normal pregnancy. Similarly, when we look at cardiac activity, we're going to be doing that on M mode, rather than using color spectral Doppler. Okay. With all ultrasounding, we'll scan real time as necessary and figure out really what's going on with the patient, correlation with, what's going on with patient's symptoms. Okay. So once you have a sense of what's going on with the patient, have done all your homework, we'll go and we're taking a look here first. First provided images are of the cervix. So we're going to take a look at the cervix and uterus first. At least in this sort of study. And the first thing you want to know is the cervix open? Is it closed? Is there abnormal shortening? Are there mass lesions, cystic changes, post-procedural changes? You want to take a look at that if that's kind of the first provided images. We're going to go and take a look at the uterus. Again, in usual sense, overall dimensions, focal lesions, post-procedural, post-surgical changes, C-section scar, things like this, and then kind of look at the usual myometrium, endometrium, as is usual. Then we're kind of basically, and we're capturing it a little bit here on these images. But once you've done the usual look at the uterus and such, the major kind of focus of this exam is to localize the pregnancy, and here we can already see, although we haven't measured it yet, and let's go forward to see where we do get that, and we'll come back to the remainder of this with anatomy, is finding where is the pregnancy. So in this particular case, it's very clear that we have an intrauterine pregnancy, but kind of major important signs to be looking for are, early on, is there a cystic structure, in or adjacent to the endometrium? Do you see the decidual or double decidual sign? Can you see an actual yolk sac? And here we see pretty clearly. And then you want to, if we don't see an intrauterine pregnancy, and especially we have to be careful about kind of like, just fluid in the endometrium. If we're not seeing a clear yolk sac or these other additional signs, are we localizing, potential cystic structure near an ectopic location, even cervical, an interstitial pregnancy? Are we seeing the adnexa intra-abdominally? And if we are seeing the adnexa, can we, frequently, it'll be in one of the fallopian tubes. We have to be very careful to separate, to distinguish that from the rare actual ovarian ectopic pregnancies. So these are sort of things to think about. And yes, also if there's C-section scars, is it related to that? And then we just being careful, and for the very rare instance of more than one pregnancy. So to keep, to remember to be checking all these locations. Okay, and so as we're going through, once we've found that pregnancy here, it's pretty obvious. You're going to measure the gestational sac to find that mean sac diameter, and then we'll have the measurements of the yolk sac, and then if we do see a crown rump length, then we have it here measured. We'll have that, have those dimensions as well, comparing these to kind of charts to get the estimated, fetal age. And then we'll kind of go through and, we'll have all those measurements. Here we have a cine looking at fetal heart rate, and let's just see if we have, once we get to the end of this, what you want to do is once you get to an image here where we have M mode performed, to get a sense of what is that actual fetal heart rate. And it's going to be important when we're looking at that fetal heart rate to make sure that we are capturing the actual movement within an area expected to be fetal heart, and not capturing, maternal heart rate, and making sure that if there's a correlation between that and, activity that we are seeing on cines. It can be useful also to correlate that with normal values for the gestational age in terms of fetal bradycardia or tachycardia. There's charts for this. And then getting a sense and comparing any of these, measured quantitative values for the currently accepted criteria for suspected or confirmed failed early pregnancy or non-viable early pregnancy, as we'll say. So we've gone through and we've looked at some of the fetal measurements. Kind of an important thing to go through, and we've kind of, from the beginning, when we were looking at the overall anatomy, we've looked at the gestational sac, the yolk sac, we've gotten those dimensions. One of the things we want to keep in mind is to look in around the pregnancy and look for perigestational hemorrhage. If we do see one, we want to get its dimensions. We want to get a sense of the overall percentage coverage of the gestational sac, as that has prognostic, meaning as to how much it is relative to the size or coverage of or surface area of that of the pregnancy, and so I've kind of glossed over that we are also evaluating, the cervix, the uterus, and then eventually we get to the ovaries, and these are assessed generally in similar fashion as to the usual transvaginal or the pelvic ultrasound. Kind of important to get a sense, the ways it kind of differs, in, especially with the cervix, we talked about open and close, or other changes. With the ovaries, in addition to looking at size, normal position, things like this, we want a sense: are we seeing the corpus luteum? Which side is it? If we can't localize a pregnancy, can we be clear and see distinguishing corpus luteum from potential adnexal ectopics, things like this? Are we looking at we want to look at the distribution of any follicles that we're seeing in the ovary. We want to see flow on color Doppler. We want to see normal resistive indices bilaterally. Preservation of the venous and arterial flow. And if there's pain, pregnant patients are also at risk for torsion, and we want to also take a look at: is there enlargement? Yeah. Is there mineralization? Is there abnormality, twisting of the vascular pedicle, things like this? And this is going to be useful to look both, on the color, the spectral Doppler images to see preservation of the venous and arterial flow, normal resistive indices, and then on color Doppler to see is there actual, flow to the testis, and the ovary, and then looking at that adnexa to see other mass lesions, other twisting, and we'll do that for the bilateral ovaries. Okay. Let's see. And then, as usual, on these kind of pelvic or transvaginal ultrasound, and similar to as on the ultrasound of the first trimester pregnancy, we're going to want to look to see if is there free fluid in the pelvis. Are there other abnormalities, whether obvious mass lesions, free fluid, hemorrhage, etc., in the pelvis, surrounding, the uterus and the and Morrison's pouch, and kind of looking to see, if there's anything here. If we see the bladder, we want to assess that, look for, usual mass lesions, things like that, if we see that incidentally. And then at the end, just, in terms of, again, taking a step back, putting this all in the context of the patient's symptomatology, how far along they are in their pregnancy. Okay, so as a recap, how do we approach the first trimester pregnancy ultrasound? We get a sense of what's going on with the patient. We have a sense as to their symptoms, prior imaging, what is their, last menstrual period or expected gestational age. And then we go through the anatomy, looking for where the pregnancy is, number, viability. We're looking for perigestational hemorrhage. We're looking at the normal, we're looking for the uterus, cervix, especially the cervix open and closed. We're looking at the ovaries, especially for signs of torsion, especially in the setting of pain. We're looking for the corpus luteum, and then we're looking at the intensely imaged additional peritoneal and pelvic structures.